Hi, this is Holly Fulmer.
And I'm Jordana Meyerson, and we're here today to talk with you briefly about opioid use at end of life.
Pharmacological therapy, in particular opioid use, is the mainstay of symptom relief at end of life. Our objectives for this brief presentation is to explain the general guidelines for opioid use at end of life and help to inform nursing practice regarding the indications for opioids, how we use them, and side effects that can be seen. The first bullet point explains the mechanism of action of opioids. Some commonly used opioids include morphine, hydromorphone, oxycodone, fentanyl, and methadone. However, opioids are not just used for pain, but can also be used for treatment of dyspnea and addiction. Though historically morphine has been a drug of choice for alleviating dyspnea, all opioids are equally effective for management of dyspnea. Patients often experience pain and dyspnea at the end of life, and opioids are either initiated or titrated to treat these symptoms. For opioid naive and tolerant patients, the clinician typically starts with bolus dosing to determine whether a continuous infusion might provide better pain control. Though there is no upper dose limit for opioids, we sometimes see patients on high doses of opioids without adequate analgesia. In this case, we think about rotating to a different opioid. Opioids are metabolized differently, and in patients with renal or hepatic failure, we think carefully about what opioid to select based on how it's cleared from the body. If a patient is at end of life and stable on a regimen despite renal or hepatic failure, we might not consider changing their regimen, but we might adjust the dose or dosing interval. However, if we are starting an opioid at end of life, we would take these factors into consideration.
The reason we care about how opioids are cleared from the body is because toxic metabolites can accumulate in the blood and cause many adverse effects. One neurotoxic adverse effect we can see is myoclonus. Myoclonus is the symptom of involuntary jerking of the muscles that can be caused by opioid metabolites at any point in opioid administration. This can be really uncomfortable for patients and ultimately can lead to seizures if it goes undetected. If we do see this side effect, we would consider changing to a different opioid. If this is ineffective, or if the myoclonus is really severe, we might consider treating it with an agent such as a benzodiazepine or baclofen. Another neurotoxic effect that can be seen from opioid metabolites accumulating is hyperalgesia. It's hard to believe that a medication we use to control pain can actually lead to increased pain. However, it does happen, and sometimes in the setting of increasing doses, and it's tremendously uncomfortable for many patients. Even touching the skin of a patient with hyperalgesia causes significant discomfort. If evident, it's indicated to lower the dose of the opioid very quickly and change to a different opioid. Sometimes when a patient comes in with delirium, their opioid medication is thought to be the culprit and it's stopped. Just as a refresher, delirium is a condition in which patients experience inattention and global cognitive dysfunction. However, delirium is rarely caused by opioids alone. Pain can cause delirium, so rather than stopping an opioid due to delirium, we recommend looking for an underlying cause and treating that underlying cause with ongoing pain management with opioids. If other etiologies are not found and it's truly felt to be the result of the opioid, the dose can be lowered if there's adequate analgesia, or the opioid can be rotated to another opioid. Considered to be one of the most concerning adverse effects of opioids, respiratory depression is actually a rare side effect if opioids are being titrated to the level of the patient's pain. That said, monitoring for this complication is highly important, and sedation, not respiratory rate, is the first indication of overdose. If respiratory depression, such as a respiratory rate less than 10, due to opioids, is suspected, stopping the opioid and giving a slow infusion of naloxone is recommended. We can't stress enough that a slow infusion of naloxone should be given, as a high dose bolus is likely to cause withdrawal and increase symptoms in patients during a very vulnerable time in their lives.
In summary, opioids have many benefits in helping to control symptoms at end of life and are first line therapy for controlling pain and dyspnea at end of life. Nurses play one of the most important roles in making sure these medications are used safely and effectively for their patients.
And if patients are experiencing negative consequences from these agents, there should be a plan in place for changing the regimen while still ensuring adequate symptom management.